So I'm very happy to be here today. For the last 20 years, the mission of my educational research is to solve the kidney donor shortage with no one left out. Did you know that 1 out of every 7 Americans has chronic kidney disease? And 660,000 of them have kidneys that don't work at all. 30 to 40% of these patients in the second group wake up one day and their kidneys don't work. They never even knew. That is a scary day. Chronic kidney disease is an epidemic. And if your kidneys don't work, you go on to dialysis. Patients spend 20 hours a week hooked up to a dialysis machine to remove waste and fluids from their body. Dialysis is life-saving, but it's hard. It's a part-time job to stay alive. Many patients can't even pee. I often hear, I can't believe I'm going to be on dialysis for the rest of my life. Family members are worried, and they should be, because only 42% of patients on dialysis are alive after 5 years. There has to be something better. And there is kidney transplantation, where one person gives a kidney to someone else. And compared to living a life on dialysis after 5 years, if you can get a kidney from the waiting list, you will live a lot longer. But in California, people are waiting 7 to 10 years for a kidney from the waiting list, and many die before their number comes up. If a friend or a family member offers to donate a kidney, then these same patients could get a kidney within a year, and 85% of people who get a living donor kidney transplant are alive. Transplanted patients, and all of these are real people that I know, have more freedom, energy, and can return to work. They often say that their life returns to normal and their family has them around a lot longer. But sadly, not everyone has access to transplant. In the last 20 years, while white patients have gained more access to living donor kidney transplant, for all others, access has gotten worse. Across the country, Hispanics and other racial and ethnic minorities are more likely to have kidneys that don't work and less likely to receive transplants. Within safety net organizations, Within safety net organizations, we have patients that also need more help reading health materials and who face an inefficiency and a complex transplant referral process. So what else can we do? Let's change this. With my diverse team, for the last 15 years, I have developed innovative educational programs that have been shown to increase transplant knowledge, referral, and pursuit of living donation, predominantly in English. These health literate programs are in dialysis and transplant centers across the United States, in print form, in postcard form, in texting, educational programs that you can get on your phone, through animated decision aids, where you can find out what's the best treatment for you. And finally, through a library of real patient stories, where you can find a story of someone who looks like you and maybe speaks your language. So the final part is, after you learn, you also can figure out how to find a transplant center near you, like Harvard, UCLA, which Safety Net community members are welcome to go to. And you can raise awareness for your need for a kidney using social media. So with improved resources like this, transplant is possible for Spanish and English-speaking patients receiving care within Safety Net communities. The goal of our program is to increase living donor kidney transplant rates in the Safety Net community. Using community-based participatory research strategies, I now want to create a tailored educational program designed with and for the Safety Net community to reach patients and prospective living donors in English and Spanish. We want to tailor education so that it's easy for providers to give out, easy for patients to use, low cost, in Spanish, and culturally relevant. After building this suite of materials, we want to work with different organizations to improve the referral process, leading to patients and donors showing up to increase living donor kidney transplants. We've begun working with many community clinics and with Harvard UCLA directly to look at how referral happens and how we can make it more smooth. We now seek funding for a 2-year program where we want to support community research, new education design, intervention delivery, and analysis. We will conduct focus groups with community leaders, patients, family members, and living donors in English and Spanish to learn more about barriers to transplant education and care. We will build this suite, stories in Spanish, text messages, print materials, an animated decision aid, and referral practices, all in English and Spanish that can be utilized by the SafetyNet community, and conduct a pilot intervention with 100 patients and their families to assess how helpful these resources can be for increasing referral. There are patients we haven't reached yet who have loving family members and friends who would consider becoming living donors for them if they knew more. With your support, these patients have a chance to have their life return to normal. They will live longer if this project is funded. That's why I do this. Let's level the playing field and help everyone explore transplant. Thank you. Positives, please.
Excellent. Content is much more streamlined and focused. Even though you were reading, the presentation was still really good at this point. So by the time you don't have to read it, it'll be fine. I liked your slides. They're simple. They tell the story. And I think you're right on track for moving it towards to the final.
Great.
Now, do you want to go around for all the positives, or do you want to go?
You can do it however you want. No. Yes. However you do. We're creating it today as a group.
I'm gonna go. I like your slides also. They were very easy to follow and matched your story, and it was great. It was really great. I like how you turned it around. So good job. Mm-hmm.
How long was it?
6 minutes.
6 minutes.
Yeah. It was actually improved from last meeting. Last meeting I believe it was 7. So now it's 6. So.
I can also add that the slides were great. They're simple, they're to the point, they're not too much information. I'm going to also give you some constructive feedback. Some of the data, it got too much for me at points where you were sharing the data about being alive after 5 years, like these different
That was too much for you.
bars.
Okay.
I did tune out a little bit, and then I came back in when you addressed the whole gamut, not just the videos. I like how you're talking about the materials now, the postcards and everything. So I think you're giving the big picture and addressing all the aspects. So I love that.
Great. How about other people with the data? Too much? I wanted to hear other people.
I think you can probably cut some of the slides, because you have the slides up there and you have to process it and you already jumped into another one. So
Yes,
maybe,
would you, great.
so maybe just pinpoint what are the real salient data points that we want to remember.
Yep.
And I think also from the beginning, you state the problem and we're kind of waiting for the solution. So maybe my suggestion would be, let's give a little inkling of what you're going to solve. You know the problem, but you got this thing, and then you're going to take us on the journey to it.
Okay, you want to hear what the solution's going to be before we
A
present
little
it?
bit like a tease.
Okay.
Right?
Okay.
And you want to grab me.
Great.
That'd be
You're telling me that research now needs a sizzle reel? So I have a big positive, because after our last meeting, I challenged you with, if this works, is Harvard ready to take the influx? And the answer was absolutely yes, all the way up to the chief medical officer.
Oh, wow.
So,
Great.
the slides also, I think, are simple and straightforward. The thing I try to do is use different words in what you say than what's on the slides. One of the things that tunes people out is if they hear the words on the slide, they either stop looking or stop listening.
Yep. Great.
So I'll also feedback the pictures where you have what's working and what's not working. You have the kidneys don't work with an X over 1. You should have the X over 2. Because most people will say, well, wait, if one kidney's working and one kidney's not, why do they need the transplant? because then the donor is living with one, so cross them both out, neither's working. And then the slide on the educational material, I still was having a little difficulty, getting to, you know, safety net people die at a faster rate, and they because they don't have access to donors. But remember when you stopped and you said, "Oh, I need this slide up here first"? If you go back to that slide.
Sure. So you just tell me when you see it.
Yeah.
Okay, so we can go with.
There.
This one?
Yeah.
Sorry.
Yeah, so, I wasn't, if I was just reading this, because your narrative wasn't quite matching the
Mhm,
slide
right.
for me.
Agreed.
I was like, okay, so what does a higher kidney rate have to do with reading material and inefficient transplant
Mhm, yep,
referral
agreed.
process?
Yeah.
So somehow tie it together a little bit better.
Yeah, I love, so one of the things I wanna be very sensitive to in my speaking is that I'm not in any way offensive to, you know, the care delivery happening in the communities, and I'm using the right language and the community that we're serving. So the thing to me is, how do you say, so in general, like, this is the question for the group, so in general, there's challenges with getting transplants, right? And then there's an additional burden in this community for language reasons, for, you know, transportation reasons, for all of this. Can I say that without that being?
So Mitch
This is-
Katz
that's what
just
this-
did a TED Talk.
I'm sorry?
Mitch Katz, our former director, just did a TED Talk. He, watch it and recognize that nothing he says is offensive,
Mhm.
and your meter will go way over from where it is now.
Because he's head of New York now. Yeah, he used to be LA County now, and New York's the biggest one, right?
New York is the biggest non-federal system of care.
Right.
I can move on this to talk.
That would be great. That would be great.
Because
That's what I'm wondering, because it's like, this goes back to me, so like, I've done this, so what we all know is, we've done this in other communities, and this is never trickling down. So, in talking now, I talked to all of you, I talked to, you know, Venice, I talked to other ones, and it's like, people are just like, this isn't even there.
Yeah.
That's what I
I
can
mean,
tell you.
not for this presentation, but one thing to maybe think about when you say trickle down, it has to start somewhere, because you don't have anything about provider network information, you know, about informing even providers that they have this opportunity to talk to their
Right.
patients about. You're targeting the patients to be aware and asking for it from the provider network.
Yeah, we
So-
could talk about, that's great, so we could do that in this part then, right here. So we've been trying to name the intervention the whole time, right? So I have all these resources, and the idea is we could build something. We were unsuccessful in finding the perfect place, but the sense from the last coaching was that we offer this to anybody with a Hispanic and, you know, bilingual community of kidney patients, like, we're open. That's the piece that's been kind of stopping our flow.
Right, but on that one slide where you said this, it's three, it's the provider network, it's the patient, and
Where?
no, the previous one. There.
This one? Yeah.
Patients, community,
Sorry, my bad.
Yeah.
Driving down.
patients, community, and safety net. So
Do we need
this,
to address each one?
I don't know if you need to, but if you're not going to, maybe think about that, because.
This was the referral part, right here.
Right, but so you're talking, your whole presentation is about patient education.
Right.
It's not about community education, not about safety net education.
Right.
So if you don't want to say, we want to get the words out to the patient's community and the safety and the providers, and one way we're going to do that is to focus right now on the patient group, then you can leave this slide in.
Well, the intention was to find the partner as a part of this competition, and we did not successfully do that. So the thing to me that
we're left
When you
with
say
it.
you didn't successfully do
Well, the
that.
hope was that we would partner with Venice Family Clinic, and they didn't have enough patients.
Right,
Right.
but you mentioned Harbor, so I don't know that you, again, that you need to identify your partner for this upfront.
Well, I can't, so the answer is, that's no longer
Right.
a choice.
That's fine, but what I'm saying is, if you're just targeting patient education, I don't know that I would say the triad.
But I don't, it has to be embedded into workable systems for this to be valuable, would be my feeling. I don't think it's like, here's great education to patients, you'll never get it. It has to be usable within a care system, would be what I would, it would be my response if you were a judge, you know, asking me, like, it's available now, you can go online now. Do you know what I mean? So the feeling to me is, I can say that,
Well-
but we didn't go that direction.
Okay, so then,
Do you want me to continue?
Please,
Yes.
please, I'm listening, I'm open, we're deciding.
So I do agree with, so I'll put I'm a nasty judge hat on.
Please,
You
you
want-
do that well.
wait.
You'll thank me at showtime.
Yeah.
That dress rehearsal was so tough. You want 300K for what exactly?
So we do formative research with the leaders, we recruit with the leaders. We build all the education that we don't have in English and Spanish, some of this isn't in Spanish. And then we do a intervention for 100 people that we see if we can get and their families within a care system to move them forward to living donation.
Okay, so that translates to $300 per person in your test group of 100, correct?
Correct.
Okay. And how much of this is transliteration into Spanish?
60K of it.
Okay, and then how much of it is development of new materials?
That's all of it. So translation, yes, all that. The rest is meeting with people and, also, the safety net organizations ask for money as part of this. They didn't say they would do this for free,
Right.
right? So this is staff and educators and referral and all of that.
Right, because it's a new expense for them.
Correct.
So how is this sustainable?
How is this sustainable?
Yeah, because so for everybody, all funders, when they start a program, they either like to invest in capital and infrastructure, or they need an absolute understanding that a program will be sustainable, because they hate to fund something that's, a member clinic is using research funding
Right.
to sustain a person, and when that research funding goes away, that person and therefore the program falls apart.
Yep.
They are completely done with doing that.
I totally buy it. Here's where I'm stuck. So I needed a partner where this could be built into their system, and I didn't find them. Now we're saying, looking for partners as part of this. That was the coaching from the last time. So what I can say is all of these resources are then going to be available. And most of them do not require printing costs afterwards. So the programs are sustainable and available. Then the second part is how do they build that into their normal care delivery system. And my feeling on that is that in talking to the ones that I did talk to, they're like, oh my gosh, we'll connect this with our active diabetes program so that, because a lot of those patients need to hear this information, and we will create a kidney health program newly, and blah, blah, blah. So it went from there. So they were connecting it to their processes. And so I'm up here going, I don't know how they are going to make it sustainable. In some ways, I'm going to test whether it works or not. We don't have to test that it works. We can make this a lot cheaper if you think it's not a sellable
Well,
ask.
it depends how much of the expense is making it what I'll call a real experiment versus an experiment of convenience.
Right.
Lots of people take experimental convenience data as enough for something like this, before putting in big money for things. So here's the question I would ask.
Yeah.
The patient's clearly a winner. The patient who gets a living donor who would otherwise have stayed on dialysis. Who else is a winner and who's a loser when that happens?
Dialysis centers are losers.
I'm sorry?
Dialysis centers are
Okay.
losers.
No one's gonna cry over that. Who else is a winner?
Well, to me, the organization that's taking care of them, the patient long-term is a winner because this patient's gonna be healthier, right?
So is the cost per year of a post-transplant patient globally less costly than the cost per year of
Yes.
dialysis patient?
Yep.
By what factor? You have to.
The working, data is that if you get 5 people a living donor kidney transplant, you save the government, Medicare, $1 million.
Over what period of time?
I can go back and get all the economic work.
So put it all in terms of annual, because cause $1 million for 5 people is 200 grand. Over lifetime, and people who spend over their lifetime each about 4 million. That's a different number than an annualized one. So if the annual expenses have a significant difference, then figure out who's saving that money, and that could become your sustainability plan.
Let me ask a question, because it's really, really, really helpful. So, I can do a research study to prove that this works or not, right, or that it fails. Like, we can set that up and just test that in small or large communities. Is the purpose of this competition just to build the resources cheaply?
The purpose of this competition is to do 2 things. One, connect people who would have trouble getting funding to funders who are looking for non-traditional ideas.
Right.
The other part, which everyone who gets selected gets the benefit of, is really teaching a skill to everyone who goes through this program that they will use for the rest of their lives and careers. So, we still hear from our first year folks, this great thing happened to me, and it was because I could present my story in a different way than I ever would have had it not been through. So for those of us who run this, that's frankly a bigger joy than the one person who got a prize or the one person or 2 people who really did get a funding connection here. So that's why we do this.
Yeah, got it. And I appreciate it very much.
But going back to what question is, if half the research funds are to make it blinded, with data stewards and all the other heavy duty stuff that costs a lot and is really important in real research.
Right.
This is something where soft research will be enough, because this is kind of touchy-feely interventions anyway. And the question becomes, is the effectiveness of this because of the personality of the person delivering the message, or are the materials that you create so compelling and so good that the person delivering it makes less of a difference?
Okay, so a follow-up question then. So, all right, so regarding this, we can make the whole game of what's the ask. We've all been talking about that, right? So we can just say we're gonna build materials and have conversations with weaving it in, and then giving money to safety net organizations if they want it to roll it out. And unless you don't want us to do that, like, to me, that's what they ask for. I try to make sure the ask includes
Right.
the test of it. There.
Absolutely, and no one is going to do clinical research in their environment without having their costs covered.
Totally, right, yes, so to me, so I'm not sure, so the fact that if they're asking for money, that it's not long-term sustainable, I don't really.
No, so the asking for money is the proof that it works in research. A separate thing you should be doing anyway in your role is figure out if the cost per year of life-sustaining treatment is truly significantly lower post-transplant than without a transplant. I'm not talking about quality of life. I'm being the bullet-headed accountant.
Yeah, the economist, I understand
dark
totally.
green
Yep.
dollars. If you can prove that, and show that, and there's a significant delta, figure out who's not spending money that they otherwise would have spent. Not because it feels good, but because it changes their bottom line.
Right, agreed.
And those are the people we need to think about how to make this sustainable. Because this does have higher costs on the front end. You're doing, you've got, unless you can completely automate the communication, these are communications that are not happening at all today. So the cost of doing any communication, when the cost is zero, because it's not happening,
Right.
it should happen,
Right.
but it doesn't,
Yep.
is a
It's gonna add
cost.
money, right.
So you need some way to get that cost.
Yes, I can
Okay.
definitely build that case, thank you.
Does that
Totally
make
got it,
sense?
I totally got it, yep. So the only
that
thing
make
for me,
sense?
yeah, basically, I need an economic case for like the cost savings long-term of if you're shifting safety net people from dialysis for their whole life to transplant, you hit a 10% success for that, what this will mean in savings, that an insurer would cover that.
So return on investment.
Yes,
So
yes,
ROI.
very clear. Yeah, no, I appreciate it. We can add that in. Okay, let me ask, this is where I'm stuck though, because when we were coached, a couple of coachings ago, it was like, you need to show the whole thing, right? It's not just, so I've gone from like, here are cool resources. And then people are like, we don't even want to see the resources or the videos. We only want to study, so then we built a study and now it's like I'm trying to land in the right, my pendulum went over here and it sounds like it went too far over here. I'm trying to get to the right middle.
No, I think you're pretty close.
All right.
I think we just want to, like he said, return on investment, here's upfront development and testing costs.
So do you
and-
want a study to happen or do you want me to not
No,
just
I
give it to
definitely
them?
want a study to happen, but I want a study with the right degree of, where's Laura?
She's not here today.
Okay. So I was gonna use her as an exemplar. So we're funded and so is UCLA, LAC, to expand the use of a particular technique for hypertension control. And they have funded us to the extent of implementation, but specifically, they're like, we do not want you to spend money on a blinded,
Yeah.
randomized, prospective research design.
Yeah, that's
You-
what,
You can spend this much on, observational measurement, but do not, if we
Get
sniff
it.
out that you're treating this like real research, we will pull your implementation funding.
yeah, that's clear actually
And-
to me, thank you. So
and-
it's
and
basically
so-
get it to them. This is what it costs to get it to them. And we'll do some minor
And this is the
measuring.
effectiveness of it, just measured, unblinded, unrandomized. Here's what happens. Because you know how many referrals Harbor is getting from each of the safety net providers today. At least they know.
We know.
And which I assume that you know, but I know they know. And you could look at it, just showing the delta over the places where this was implemented. It's called the step wedge design, if you want the research term. You just measure referrals from the places where it's implemented versus just your baseline everywhere. Then you look at the delta in the places where this is implemented versus where this is not. And the wider that divergence is, the difference of differences is the net effectiveness. It
Yeah.
requires no randomization. It's very easy to track. It's a reasonably good research design, and it's not expensive.
Yeah, yeah. So I'm hearing, if I could just say that and you guys go yes, because then I'm just trying to land what I'm doing, right? So it sounds like we are working, finding our partners, doing discussions with the leadership, of the clinical leadership, learning about the systems, talking to the patients, talking to the donors, talking to the families. Based on that, creating an optimal set of resources that are currently missing. And from there then, doing an implementation pilot to look at when rolling these out in certain communities, does that ultimately lead to donors coming forward and patients moving forward? Just like, wait, I need a yes or no, and then I want to hear.
Actually, can I hear the burning comment first? And
I was just
then
gonna
I'll give
suggest-
you the yes.
You should, the issue, your North Star of your whole presentation should be, we're gonna save lives and save money. So every point, every slide should direct that. We've got the process, we've got the partners, we're ready to save money. Make that investment with us.
Great, thank you, love it, love it.
So just have, because you have, like, all of our projects, there are so many layers to it, you know, less is more, so, you know, every point should be, we're gonna save these people's lives that are underserved, and we're gonna save the system.
Yep.
And the answer to your question is yes. It's not a qualifier, it's a, I'm losing the word now, but, you talked about Venice as our partner, as in unity, you know, you one, but they didn't have enough patients. No outpatient organization in one location, or even, you know, even the largest FQHCs, are gonna have enough patients requiring transplant to make this sustainable. You will need dozens of feeder sites.
Yep, we agree.
And so I wouldn't,
I was thinking that.
so maybe, or, you know, talking about, you know, patients, the from, the process, and the to. And right now, your two is an N of one, it's Harvard. And because in the safety net, that's the only game in town for kidneys.
I heard there's some others. Emily, what did you hear?
County USC was mentioned, but USC said because of the API insurance that it's not a real option.
Okay, so you, all right. I know you're the boss.
I know that Harvard is the only real option.
Other people are disagreeing with you in the field, so I don't understand, but I trust you.
Because it's by design.
Okay, so they're all going there.
Yeah, you know, we have made some hard decisions in LA County Health. So if you have end-stage heart and lung disease and you don't have Medi-Cal, you're gonna die. Whereas people of means with transplant insurance can get a new heart and lung. That's just, it's that or close more health centers kind of decision making. It stinks, but it's real. We made a decision about kidneys, we made a decision to focus them in one organization so that they get high volume and get good at it.
Center of excellence creation, you know, within the safety net, instead of
Okay.
having 10 at each site of, you know, 50 at one. But I think you're struggling with this, who's our partner side, who's our safety net feeder side, and I don't know that.
You have to bother struggling.
Right, I don't think it's a struggle, I don't think you have to worry that.
You've got CCLAC and LA County Department of Health as
Your
between the
feeder.
two of us, we have 2.5 million patient pace.
Oh, so are you willing to be my partners?
Well, it depends what being
Nobody's
your
offered
partner.
me.
So
Hold on, I'm
so-
really glad I came today.
So now that well, it's part of the reason I checked in with Harvard.
Sure.
Because everything that everyone is doing here is real
Yeah,
and affects real people.
yep.
So, when it was clear from Harvard that they're interested in doing this, you know, I'm happy to do a letter of intro to all of you. You've been there already, but just to say, look, this is not an endorsement from my office, but I think it's worthwhile that you meet and talk and decide with your renal folks, with your diabetes folks, with your hypertension folks, is this something where you want to enhance the referral mechanisms to Harbor to make it easier on patients who are at a transplant decision in their life and increase the likelihood that they get a transplant because part of this is doing living donor. After that letter of intro, the rest is up to you to make
Yeah,
it real.
to generate. Oh, I really appreciate it. Is that fair
Because I
too?
think that's one of your personal
That's where I've been stuck the whole
struggles with this
time.
whole presentation is that you set it up with Venice and then Venice doesn't have the volume and now what are you doing?
Right, like, cause I'm here, I have resources, I'm happy to make them available in places that they could be valuable, right? That, I knew that from day one, but then it was like, well, who could make it
And so
valuable?
I don't think you need to name a site. You have your transplant site.
Can I say I have, what's the right phrase that I say when I'm
The
up
two
at the front?
largest organizations, here, I'll just.
Thank you, please.
The
Yeah,
two
right.
largest organizations representing the safety net delivery system in LA, the Community Clinic of Los Angeles and the LA County Department of Health Services, are willing to have and I don't mean to speak for you and
You can go for it.
but I know how your organization feels now, are willing to allow us to communicate with their members and facilities to find places of synergistic philosophy, desire, patient volume, and clinical conditions. Between LAC, I wouldn't go into this much detail unless you're asked a question, but literally our unique patient population between us is over 2 million patients annually. That's a population that's plenty big enough.
Yes, that is. Thanks.
Sure.
Like within CCLAC, we have 65 community health centers. Venice is just one of them. So thinking about when we matched you with Venice, our idea was more on the storytelling piece, but you can have other partners in this journey of
Right.
yours, and we're happy to.
Great, thank you.
And I can
Yep.
speak for my organization, because I know we've done this in the past, like getting access to our providers or our care group network, so you can spread the message to the providers.
Yep, so we go give talks or
Yes.
build partnerships and,
Correct.
yeah, that would be great. Great, so I don't wanna take their time.
And so just going back, so while you're asking for funds for development of the messaging to the patient population in English and Spanish in a safety net situation, you may wanna throw in something plus messaging the providers
Yes.
that this is available to their patients so they, have that connection back to the providers. That was my only.
Love that. I love
Oh,
that.
thank you.
I've
When I
been
said,
like
you know,
stuck in this for like a month, so this is like exciting.
Yeah.
Oh my God, humans, then I can help, that's all I
Right.
need, right?
Right.
Last question, do we want any heartfelt storytelling stories? That's where I started at the beginning, that's pretty much all I had at the beginning,
Well, the
right?
only thing is you have a lot of slides
But
of
we'll
these
probably
kind of
we'll parse it
composites
down.
and other, that I can't read it, it's too far away, I can't see anything on this slide, for example, from where I'm sitting, okay? So this doesn't help. If you have one or two of these on its own slide, at least I can see it, I can read it, but it's not that necessary to keep having so many slides as you're talking.
Yeah, that's what I said too.
And depending upon your time, which you tend to be slightly over, you may not have time to do that other, which is
I
what you
understand
started
all
with.
that, I understand all that, but
If
my
you could
question.
pull at my heartstrings, you're much more likely to get funded.
That's
Right.
what my question is. So I can cut other parts of this complexity if you want a story and do, I just wondered, you guys have, heard.
Do you have a good story?
We have a million good stories. Yeah.
Pick one.
Yeah.
Two does nothing over one.
Okay, all right, great. Okay, thank you guys. What, you had more?
I was gonna say, I think if you're gonna do a story, use it as a tool to make what your plan is more salient. So maybe like starting briefly with it and then revisiting that person as to how your plan could help them along the way.
Did help them.
Yeah, so I wouldn't do like one big thing at the beginning. I'd almost like have that be the thing that ties it all together.
Great, great ideas.
I want to keep us on track.
Thank you.
So let's move on to the second presentation.